Hi, everybody. Thank you for joining us. We have some of our panel just still trying to join us. Greg and Nick, if you are, you need to click the Join Us button in the right-hand side of your screen. But we have Danny and we have Aaron, and my name is Kate. For those of you that are watching, you can type us questions. On the right-hand side, you have an Ask Chat button, an attendees, and a poll. So have a quick look at that. I think we have a couple of polls throughout that you guys can take part in. In fact, Beth, have we got one that we could pop up now just while we are waiting for the boys to come on?
Sure, I can get that up now. 1 second. Thanks, everyone.
Okay, I'm going to start and up in a minute so everybody can see what we are talking about. There we go. Thank you very much. Okay, so today we're going to do an introduction, a very brief introduction to CCMI and our response to COVID-19 in March, from March 2020 onwards. We will introduce today's webinar panel, who are very seasoned and experienced, and each panel member, hopefully if we can get them all on, will give a short overview of their experiences of COVID-19 and will give a summary about what is their most important piece of advice. Questions can be submitted throughout. Please use the Ask Chat button and we will do our absolute best to answer anything that you guys have to ask. Okay, so introducing CCMI. We operate a remote field station. For those of you that don't know us, and there's quite a few people on the call that are not in the Cayman Islands, it is based on the north coast of Little Cayman, and we have direct access to Bloody Bay Marine Park, which is 50% MPA. It has a healthy coral reef ecosystem, so it's an absolutely stunning location. We specialize in tech diving, and we have on institute lab facilities that makes between the ecosystem and the site provision that we have. It is really unique for studying climate change and adaptation and pressures on biodiversity. However, with Paradise comes the other side of the coin, and that is that it is a 30-minute flight from Grand Cayman, and that is via a propeller plane. It is not a jet, which means it doesn't run after dark. 250 people live on Little Cayman, so it is very small. There is limited infrastructure. We house up to 30 people as residents, with another 10 to 15 who live on islands at any one time. On Grand Cayman and in the UK, which is where I am, so we are pretty disparate as a company. Little Cayman has really limited medical facilities. There is limited emergency access, and it is really a true sense of a remote location, even though Grand Cayman, which is a 35-minute flight away, is really well sourced or resourced. So for us, there's just to give you a real introduction as to who we are, which will help frame why COVID-19 had certain impacts with us, which hopefully will resonate with other nonprofits and other small, operations from small islands. So we have a mission to understand and promote resilience of coral reefs in changing environmental conditions. We support the research with education and conservation. Adaptation is one of the big areas that we work on. How do corals adapt to different conditions? Now, this is particularly relevant because we have deep divers, tech divers, which they need to be extremely fit for. COVID-19 we still have questions about diving in COVID, particularly with lungs and good stuff like that. We work on resilience. Can corals become more resilient to climate change? We do a lot of long-term monitoring, which is all dive related. And then we also do the offshore seamount work, looking at biodiversity and connectivity between the seamounts and the surrounding areas, which is offshore. So, from a health and safety perspective, a little bit risky. So our response to COVID-19, I just wanted to give people a really very brief description of what happened. So, and I think Danny goes into this in some detail, so I'm just going to skim across it. But on the 22nd of March, the borders closed in the Cayman Islands, and more importantly, the flights shut down. So all the links to mainland. So for any staff that we had who were from Europe or the US and actually not from the Cayman Islands, that was their chance to get out. Now, at the time, and I don't know if any of us can remember this, we all thought it was going to last for 3 months. So some of the decision making was based around that. But for us in the Cayman Islands, it was about November 2021, and people could only access still in quarantine or then with really rigorous testing. And it wasn't until February 2022 that the borders opened. And for us, that also meant that we lost an education season. So January 2023, so 3 years on, we are now seeing normal operations. So this is a 3-year impact for us, which is absolutely ginormous. My dog is going to bark. Sorry about that. So the immediate impact for us was how to survive. Everything changed overnight. The first question was, how are we going to be able to manage this? Which I think for most organizations was pretty tough. We had HR was a huge consideration. Obviously someone's arrived at the house, the dog's now kicking off. You know, how do we manage our staff with the borders closing? What decisions do we make? Who do we keep? It was huge for us because Little Cayman is so remote, and we had to try and balance keeping projects moving, keeping the business alive. What happens if the borders open tomorrow? We need to have, you know, our amazing staff versus you know, what's happening on the international stage. So it was a big deal. The psychologial impact of COVID-19, which again I think Danny is going to go into in more detail, but this was absolutely massive. So not only for people that were locked down in a remote place away from their family, but just the impact of being locked down full stop. Like, I think you know, for me, my wine content went up, but everybody dealt with it in different ways. For us, the revenue strategy had to change overnight. We had to remodel our revenue, and I built the revenue on a mixed model that was very sustainable and extremely stable, and it just changed overnight. So it was difficult, and overhead was a huge risk for us. And the overhead is, even if we stripped everybody out of the station, we didn't have any staff. The big problem was, how do we pay the bills? We have to have insurance, we have to have bank fees, all the things that you absolutely have to operate. So that changed in a heartbeat. And then finally we had the business continuity. So we did risk assess. We were risk assessing from January to February onwards, and we did have a strategic approach, which came in pretty handy. I think what was interesting is quite a few of us were not in the Cayman Islands. So what was happening in Europe was very, very different, particularly because we had Italy on our doorstep, and that was an early change. So you know, there was a lot of differing views depending on where you were based, but that, because particularly we were in Europe and we could see a lot of what's going on, we could kind of see the writing on the wall, whereas some of our staff in Little Cayman were not feeling that way, from being entirely honest. So what worked for us? Well, we had well-developed policies and HR manuals, and if anybody wants us to share our policies, I'm very happy to do that. Everything is because we operate across 3 different jurisdictions, the UK, the Cayman Islands, and the US. We do it to the highest level of whichever jurisdiction sets the bar. We also have recently got RESEMBID support to further develop our policies with a greater focus on hazard, and actually that's one of the reasons we're doing this webinar. So that really stood us in good stead, and I would say to people, you know, really do consider making sure that all your policies are in place so that you can respond well to this. We had a reserves policy and a focus on unrestricted funding, which was a huge lifeline for us. In the UK, you have to have a published reserves policy. I would say that actually it probably needed to be more generous. And without that, I'm not sure that the organisation would you know, have survived in the way that we did. The other thing is keeping your overhead low. That worked for us. We were about to expand. We had a huge HR plan because we've been growing for many years now, and we were literally about to increase our overheads. And had we done that again, I think that we would have really struggled. The one thing that also is, the larger salaries that we carry could all continue to generate funds throughout this whole process, and that was absolutely key. We were very, very lean, and anyone that we kept, because we didn't have so the other thing is for Cayman, so if you're watching this from the UK, there was no government bailout for us. We were left to just manage this ourselves, which we did, but we made sure that everybody was generating, which is a really big deal. the ability to work remotely, and also our previous management team got us a special license to operate as a key business. And that was absolutely, without that, it would just been a game changer, because we could not only continue the projects that we already had funding for, particularly the big grants, because we could just go out and do the work, but also we could deliver local education when the internal borders opened, which was an absolute game changer, because we could really, I mean, we delivered double the local education that we would do normally, because the kids were looking for something to do, teachers needed trips for them to go on. So that was a huge opportunity for us. And the only reason that we don't do that level of local education is because we don't have room, which is something that we're working on. So that was absolutely amazing. And the last thing I would say is that key stakeholders and VIP relationships, it just continues to be so very important, and it really kept us afloat is the bottom line. So it was just a huge opportunity, and continues to be. So I would definitely say for people, please, that, you know, those relationships, when if there's a crisis, is what will keep you moving forward. Ongoing considerations, which I think we can pick up as part of this, is how to keep awareness of risk alive in the business. I think there is some fatigue about talking about hazard. Our management team in general would like to focus on the good future, and not what happened and what happens if it happens again. I think that people are reluctant to talk about it. We did a big staff feedback. We had a COVID outbreak at the station in June, which luckily was only small and it was isolated. But we asked the staff, you know, what did you need? Did you feel the policies were in place? And actually the big thing they said was, across the board, the communications have got to be right. And I think if we'd have done a staff poll in March 2020, that would have been exactly the same answer. So it's absolutely huge for us. Continued focus on everybody pitching in. Again, the cross working that happens with a COVID outbreak, and it is still around, particularly for residential organisations like ours. You know, it's still flu, and you don't want everybody getting it, and you definitely don't want people getting it in a dive environment. So you have to segregate, and you have to manage it properly. So everybody pitching in is just so important culturally, and not something that I think we will be moving away from. And then the final thing is continue to develop financial models and strategies that can respond to increased risk. So that is our overview. So I'm going to hand over to Dr. Nick Gent now, who's the Chief Medical Officer from the Cayman Islands. Nick, I think you've managed to get on okay.
I think I have. I hope you can hear me now. Apologies for that problem. Yeah, I've just introduced myself as a little bit of a background, because some of the things I might say might be a bit confusing, just simply in the context that I'm currently Chief Medical Officer of the Cayman Islands. At the time of COVID, I was in my previous job working for the UK Health Security Agency. And although, as you can see from my short bio there, that my principal work was around the high threat chem bio-rad nuclear agenda. During the COVID period, I was in one of my sort of occasional supporting jobs, where I was the head of mathematical modelling in our emergency operations, which brought together not only the resources of our high performance computing and mathematical modelling and statisticians, but also those from the University of Cambridge biosciences, biomedical sciences unit, and the University of Manchester's mathematics department. So quite a big team, which, when I compare to myself and a calculator here in Cayman, is a very different reality check to what can be done with different environments and with different levels of resources. But the question that I'm frequently asked, partly as a rollover from that work, is, well, that was a once in a lifetime experience, wasn't it? And this frequently happens. People look at something that's recently happened, and they look at history and they say, well, when was the last time we had a major pandemic? Well, there was a bit of one in the 1960s, but 1914-18 was probably the worst experience the world has had that might be comparable. And they're wrong. And they're wrong in so many different ways. Firstly, most people don't understand statistics, and when they think they do, they really don't understand probability. And they like to take comfort from that poor understanding of probability, and they don't understand what are the a priori things that drive the occurrence of such events. Now, hope I'm not going to completely send you to the doctors needing antidepressants after I do what will be, I hope, a relatively short segment. Do stop me; I can talk for Britain at times. The thing is that we need to look at what are those determinants of that probability. And in the last 100 years, and accelerating massively over the last 30 years, has been urbanisation. And this is critical because that's one of the major amplification steps for infectious diseases. Infectious diseases need big populations, immunologically naive, to move through. And without urbanisation, you don't have the elements of a pandemic. Take a simple illustration of that 1914-18 outbreak of pandemic influenza and looking at COVID-19. Globally, in 1914-18, because the chains of travel, the low population densities and so on, probably somewhere between about 25 and 35% of the world population ever got infected during that period. I think it's fairly safe to say and I certainly do know from Western Europe and North America, where you have got countries with very, very high density populations, although maybe spread out in lots of different focuses, the ever been infected proportion of the population is over 90%. 1914-18 influenza epidemic has nothing on what happened in COVID-19, but it's not necessarily because COVID-19 was especially different in its ability to infect and transmit, but the underpinnings of society and how we manage things and how we choose to live has changed massively. Combine that with, then we now have short travel times. It's fascinating watching. I worked in Sierra Leone during Ebola, and it took me to get from Freetown out to the Congo border to do work over there by helicopter 30 minutes and coming back by road 4.5 hours. I watched an old David Attenborough film of his first major overseas expedition in the 1960s, and it took him 6 weeks to do the same journey. And people somehow think that those long travel times still exist into parts of the world where there are these reserves of unusual infections to which the rest of the world is immunologically naive. They've disappeared. And travel times now are such that they're shorter than the incubation periods. So people carrying infections and becoming ill in transit, and so becoming when they cross borders, that's disappeared. An example for this would be phylogenetically in the UK, we probably had 30 to 50,000 incursions of COVID-19 before the first clinical case became apparent. And when that happens, you are lost. You know, anything you do is mitigation after that. And there is not a technology that allows us more rapid recognition of such incursions. You need a critical mass of incursions before it becomes clinically apparent. So all of these things are driving what is a new normative state in global pandemic likelihood. Take that together with that we do know that we have a range of interesting infections which mutate and are therefore able to effectively be new organisms as far as people's immunological systems are concerned, then it's not a case of if but when. And all of those background effects say when for the next time is not going to be another 100 years. And it will probably be, there will be 2 to 3 such events in everybody's lifetime in the future. There are ways that we can get around this, and particularly getting away from the politicization and the blame game is an important one. But I think we all know the reality of that. And we shouldn't fool ourselves that all the new tools we developed in COVID, like the very rapid molecular diagnostics, are going to help us out of here. Because, as I say, we're only going to recognize them afterwards. And all those new tools, they're great post-mortem tools. They tell us what's happened, not what is going to happen. And so it makes a case, I would suggest, that people in every position, especially where they've got vulnerabilities, like yourself at the Marine Institute, have got to have their plans as a matter of routine. And importantly, I think one of the big lessons out of COVID-19 was that something of that scale overwhelms the state quickly. We cannot plan on the basis that the state will help you out. The state will look after you. The state will be able to help and guide in some critical areas, but unless people and institutions have prepared themselves to stop themselves being a burden on others, so the state can concentrate on the most critical elements and the most vulnerable people, then we are not truly prepared and doing our job. And so we have to have a knowledge that people have out there that it's going to happen again, that they have a duty to prepare and respond of themselves. And it is a case of what we can all do rather than what and sitting back and expecting things to be done to us and for us. But it will happen again in our lifetimes, and it will happen even the oldies like me. I fully expect to see another incident, before I shuffle off. Thank you.
Nick, I have a question for you. So I think that one of the key things that you just told us was that you need to be prepared, and also be prepared to be as independent as you possibly can. So if you were running a small, either residential or a remote organization like ours, what would you do? What would be your go-to to help make this a reality in the business?
Well, there's a lot of very good planning and preparedness materials. I'm sure Danny's got a heck of a lot of these things ready to hand. I wouldn't go down the sort of the US preppers kind of thing. We're not talking about sort of major global nuclear warfare. But if you've got to think about, does just-in-time supply fit your need to have resilience? Do you have the ability to manage, breakdowns in communication systems? Can you care for people at the maximum size grouping that you've got for periods that may be many, many weeks into the future, where you have to effectively stand alone? So the first thing to do is set the parameters of what you need to be prepared to do, which are going to be unique to your circumstances. In your case, the limitations on transport is a standout. The fact that you have got a social and you have got almost a parental responsibility to a large group of people who will be cut off from their families, their relatives, and everything else. It's about understanding where you may be in terms of the simple things about what is feasible and possible around bringing, getting people back home, or whether or not your plans have to be to accept that we might not be able to do that for more extended periods of time. I mean, certainly, there's lots of bits of people of internal stuff that you already know about, things like being able to manage incursions of infection and how you minimize those. They'll run around the whole of an organization like yours anyway, because you're a close community. You just, it's just a question of how long it takes, not if it does. And it's about also, I think, changing your risk tolerance, because at the present time we're coming from a world which was pretty blasé about respiratory infections. Hey, I used to look at people in the UK when they're saying, sort of, it's the flu season. I hope it'll be good flu season, and we only lose 80,000 people. I was sitting there thinking, that's a heck of a lot of people to just say we're accepting of that kind of loss. And now you look back on it and say, when people like myself have been saying for a long while, what is reasonable? And that is not reasonable, because we haven't taken an old-fashioned hygiene approach, not to COVID-19, but to respiratory infections, to gastroenteric infections, to all those kind of things, remembering that those are multipliers of risk. And so there's a lot we can do to just be better about doing the good hygiene and doing it well, not relying on others, and making sure we understand that we have to have a degree of reserve and competence.
Yeah, I think that's very fair. Thank you. And actually, I'll never forget watching the first advert when the government had to tell us how to wash our hands, and thinking that was possible a low point in our health management. Anyway, Danny, I think Greg is struggling to get in, so we're going to skip through to Danny. This is Danny Coleman, the Director of Hazard Management in the Cayman Islands. And she has some pretty slides.
Good morning, Greg! Good afternoon, everyone. I can actually see Greg there. Greg is there. If Greg wants to go before me or after me, it's up to him.
Welcome.
Okay. Sorry, Greg. Sorry, Greg. I just want to say, well, for starters, thank you very much for doing this in the first place. It's really great for educational purposes and sensitization purposes that we are discussing COVID or any emergency really, but again that we are learning from mistakes and again how we can share best practice as opposed to repeat those things that we may well happen again. And as Nick says, Dr. Gent says, this will happen again. We are going to see more pandemics in our lifetime. We're like any emergency. I mean, we're looking at climate change. We appreciate that actually, storms are getting more rapid intensification on a regular basis, and we're seeing a lot more. We will see more of all emergencies, I suspect, in the next few years. So I think that preparation, that education, that sensitization is absolutely critical. So again, appreciate your effort. And Simbit as well, of course. So just a bit of my background. So my background is I'm the Hazard Management Director for the government, for the National Disaster Management Office. And we were obviously very, very busy during the COVID pandemic. But even before, we were working very closely with the then CMO, Dr. John Lee, from about January onwards, looking at pandemic plans. Bizarrely enough, we were in Miami with the UK Health Services Authority, which back then was called Public Health England, doing pandemic plans, as well as working closely with other stakeholders in Cayman. So we were lucky enough to be, I guess, ready for by 3rd of March, before WHO actually mentioned it as a full pandemic. We'd activated the National Emergency Operations Structure. So which meant that business as normal had obviously largely gone by the wayside, and the entire national structure was in place, ready to go, and worked again. We were activated for 104 days during that initial stages of COVID. I know obviously Kate's mentioned that the shutdown of the island and obviously the schools and so forth. But again, there was a lot going on behind the scenes. We had a very, very strict battle rhythm every day from the 3rd of March as to meetings, sensitization meetings, press conferences daily, NEAC meetings daily, briefings obviously of the cabinet, briefings of the policy group. A lot of decisions had to be made in those early phases, and a lot of the decisions, you go into a lot of these presentations, and of course we didn't, we were working with the facts we had at the time, which was the coronavirus stays on this texture, for example, metal, for 12 hours. And then of course, by the time you get out of those meetings 2 hours later, or even 45 minutes later, those facts had totally changed. So it was a very, very dynamic playing field. And a lot of improvisation, a lot of initiatives had to be made. So I guess just talk a bit about what we those early phases of COVID, we were setting up the emergency field hospital. You'll see some of the photographs skipping through. The field hospital was a sort of multi-agency initiative, but because, of course, the supply chains were very, very inconsistent at the time and irregular, we had to rely on quite a lot of local initiatives. So, for example, in the field hospital itself, we had the call bells for the sort of really sicker patients. We used boat parts from Cayman. So there's a lot of sort of very strange initiatives being used for those the field hospital and other things. But actually, one of the great things again was, we won an award for that, a project management award for that, and even managed to beat the Rolls-Royce ventilator project, which was pretty cool. It was an international award. So, just seeing what a small island can do when you've got lots of brains around the table and trying to find initiatives, the problems we, being a small island, had to deal with. Another thing that we obviously were working on was, the shelters. We are responsible for the shelters. There's 20 shelters across all 3 islands, and we were trying to make those COVID friendly for the seasons, the hurricane season. One of the issues we did have, of course, is we look at emergencies, we look at COVID, and yes, COVID was a lot of work. We were working around the clock for a very long time, but we were also experiencing simultaneous emergencies. So, for example, we had in January, when we'd started working with the CMO at the time on the coronavirus, which was then called, we had a 7.6 24 aftershocks. We had a tsunami scare. That was, I think, it was the 28th of January. We had several dump fires that year. In March in particular, and those fires were actually very significant fires. One lasted about 5 days, and again, the NEAC was partially activated for that. So you're running simultaneous emergencies at once, which I think really does. It's quite an interesting one, and again, it requires a lot of brain switching from one to another to make sure you're dealing with both and not ignoring them. Also, tropical storms that year. We had in 2020, we had quite a number of near scares of tropical storms. So just a lot was happening at once. And I think, again, giving our staff resource numbers, it was quite difficult at times. So I think one of the biggest focus again for me today is about mental wellness and mental health. As I say, in 2019, we were working with the government, and the department was cut in half. So we've gone from 12 staff members to 5 midway through 2019. And of course, all 2020 kicked off by January with this big earthquake. It was just a really difficult time for the staff in the office, as well as the whole National Emergency Operations Centre. We had to really, really sort of beg, borrow, and steal people and train them up very, very quickly to assist us. I mean, one of the things I am always very nervous about in this line of work is just taking volunteers off the street and making them into disaster response personnel. We had to do what we had to do, but at the same time, we're doing a lot more training now to make sure the people we're utilizing in certain roles are very well trained, and so forth. So yeah, mental health was definitely a big focus of ours. We did start the focus of mental health in 2019 with the intention of making um, having that aspect, so a mental health psychiatrist, nurse in the NEAC at all times. And the intention there was to make sure that all the decisions we were making, no matter whether it was a pandemic or earthquake or tsunami or whatever, hurricane, there would be a lens, a mental health lens on all those decisions. Obviously, we all think very differently. I think specific vulnerabilities when it comes to mental health need to be considered. So that's sort of been part of the National Emergency Operations Centre since 2019, which was incredibly lucky given that 2020 required Dipno Carton, who's the nurse, has been very, very busy ever since being part of that team. One of the things, again, we did under the COVID under the NESC during COVID was the mental health helpline. And we're actually, to this day, we're still utilizing that. We're just about to rebrand that. So it is one of those things that will be seen quite a lot out and about, I think, around Cayman. Again, mental health is such an important aspect. I think we've all seen the secondary emergency being the mental health aspects now, and a lot of people are really suffering from that of all ages. I mean, I think the social side of things, even working from home in 2023, whilst it has its benefits, I do think it's creating a very different um, social atmosphere. I think a lot of our children who's experienced over the last few years being shut down, not being at school, not being around their friends, not being able to socialize, is going to, we're going to see a lot more of mental health issues over the next few years, I suspect. So that's one of our biggest focus. I think what would I do again when it happens again? Because as I say, and I totally agree with Nick, it will happen again. But what would I do? I think differently. I think um, the surge capacity at the national structure, so the National Emergency Operations Centre, we'd expand that much more. And as I say, we're working on that, training up the right people to be part of that structure and making sure that everyone's on board. And we have got good rotations, and everyone does have a role to play, but also you're getting the right rest that you need. Again, just to avoid burnout, because burnout's a real thing in this line of work. It's I think everyone experienced a lot of anguish during COVID, but I think when you're working around the clock, having to go home, worrying that you're going to infect your family with this, you just didn't know because you were around people all day. It was a real concern, I think, of a lot of first responders and a lot of people on the front line, and the exhaustion was very, very real. So, trying to avoid that and trying to make sure we have good rotations. And again, that goes for smaller businesses as well. Whilst you may not be on the front line all the time, making sure you do have those rotations, making sure you do have enough staff and surge capacity is really important. I think
So,
also,
Sandy, can I just ask you,
yeah,
sorry, so for small businesses, so I think one of the things that you're really saying is for all hazard management, but obviously particularly as COVID was so drawn out, that
yeah,
focusing on how your people are coping is
it's
probably one
such
of
an
the biggest
important
parts
thing.
of
Yeah. Making
it's
sure you're
interesting.
checking in with your staff, making sure that you're aware of all the signs. I mean, we do a lot of training in here about recognizing those signs, because I think a lot of times, you know, we may be about, especially old school, a bit more old school. It's like we don't talk about our mental health so much. I know my days in the
No,
Red Cross, we never, ever, ever mentioned,
you just get
God
on.
forbid, you mentioned mental health, and especially, unfortunately, especially the gender divide, had a large part to play that. I think a lot of the guys we used to work with would never ever talk about that. So now it's becoming a much more of a spoken topic. But mental health really is checking in with your staff and yourselves, and listening to others when they say, look, it's time to go home, you look exhausted, you really need to have a break. And you often don't realize you're treating people in a certain way. And it's those kind of things that are just so important for all of us. I think your business continuity, I love the fact that Dr. Gent mentioned that business continuity for everything is really important, making sure that you've got things in place for when the disaster, no matter what the disaster is, or the emergency
Mm.
is, you've got how do you function again as a business? How do you make sure you move forward? We saw so many businesses, both after COVID, but also after Hurricane Ivan, having to close down. And I think that's a real issue. So making sure those plans are in place for all businesses, both staffing and also how do you if you can't pay staff, if you can't have people flying in, if you can't do your educational processes. And Kate, you touched upon this already. How does your new business model look like? So keeping that in mind. I think
Mm.
also finally, knowing that simultaneous emergencies are potentially quite normal these days. So um,
Right.
planning for everything and anything and
Right.
being flexible enough to adapt accordingly is so important. And going back to the templates, business continuity that Nick mentioned, we do have a lot of resources here at Hazard Management. We do have a new business continuity officer that we brought in since COVID, late last year, to deal with all the templates and planning. So again, we're happy to review private and public sector plans. We review all the plans for government, and we do a lot of training, but happy to review any private plan that you may need us for. At the end of the day, the more private entities are organized, the better the response is for all of us, and the easier our lives are when the actual issue happens. So I think that's it from me.
Excellent.
Over to you, Kate.
That brings us very nicely into Mr. Greg Loker. Thank you, Greg, for making it.
Sorry for pinching your spot, Greg.
Yeah.
Greg actually was integral to helping us develop business continuity. And I think, Greg, actually, it would be fair to say that you were someone who has eyes really very much in front in the planning and making sure, that we have utilized your skills many times. And I know that you've done that professionally. So over to you, Greg.
Okay, thank you, Kate. So my background has been in planning for these types of on a statewide regional basis for the last 15, 20 years. And just to emphasize what again, and Danielle just mentioned, this has got to be for small businesses, an all hazards approach, and the not necessarily a pandemic, but a different event will give you a good run, so to speak. Hopefully, it's not as long as the pandemic was, but it'll allow you to validate and reevaluate your existing plans here for that, and to prepare for that. Then the doctor mentioned this resilience. In the U.S., hospitals are under a joint commission requirement of a standalone requirement. They must demonstrate on a biannual basis a 96 standalone concept. So what happened? He mentioned communication. Water was lost. Supply due to a variety of so identify where for a
Greg, we're
period of
having a little bit of trouble with your audio. It keeps breaking up. Sorry, I'm just jumping in here, but we're just losing your audio in and out. So I might ask you to repeat the last sentence that you went with there.
Okay. As you know, the internet some little came on is not.
Always an exciting challenge.
Always an exciting challenge. The last point is that the scale events were under a joint commission requirement.
Sorry, Greg. I'm going to have to stop you there. We can't hear you. Oh, we've lost you. You're really in and out.
Okay.
I think, I'll tell you what, why don't we try Aaron, and we'll come back to you and see if your connection, because your connection to start with was perfect. It's suddenly kicked off. So why don't we, Aaron, if you're okay, we're going to switch over to you. Greg, we're going to come back to you if we can and try you again with your awesome. I'd also like to say that some of the infrastructure problems, like internet connection in Little Cayman that doesn't work, is a continued issue. So Aaron, let's hand over to you for a bit, and hopefully we'll be able to pick up with Greg in a bit.
All right, thank you. I can go ahead and start. So I'm Aaron Otis. I'm the Assistant Deputy Secretary for County Health Systems with the Florida Department of Health. I am a public health officer with the United States Public Health Service, but my full-time duty station is at the Florida Department of Health. And so my day-to-day role is working with our 67 county health departments, which one thing unique in Florida is those county health departments. So their health officers all report to the office that I work with. So what that allows us to do during our responses is to have more of an integrated system. And so I actually served during COVID as our emergency coordinating officer for our emergency support function that is responsible for the public health and medical side of things. So what we spend most of our time doing is working with those county health departments. What we try to the basic model is try to have one integrated strategy. So what is occurring, or what do we need to accomplish? And then the county health departments with their partnerships work on how that's going to be accomplished, because each one of these counties are unique. If you just, I know Danielle mentioned being in Miami. You look at the population of Miami compared to the county right south of it, which is Key West. Two unique populations. And so for us to tell them how they're both going to accomplish providing medical countermeasures, testing, it's not going to be very effective for us. We just need to have what is the strategy and allow them to accomplish it. So with COVID for us, one of our big initiatives was a seniors first model. I saw something very similar with the presentation, the slides that were going on. And so what we tried to do is really utilize a lot of the frameworks that we have used for other responses and reshape those to allow us to be deliver effective services during COVID. So with Seniors First, a lot of what we did was use some of our hurricane models on how we deliver goods out to individuals, both on the medical side. So one of our primary functions is to evacuate healthcare facilities. So this was the opposite. We wanted to get services into the healthcare facility. So we kind of switched the model. We started using our ambulance strike teams that we have to provide on-site medical countermeasures. So early on, that was vaccine. We moved to monoclonals, and then as antivirals became available, we used those distribution models, whether we were going to actually deliver them to the individual or deliver them in bulk. We also utilized our epi services, increased surveillance, case investigation, and then really spent a lot of time on our healthcare acquired infection program, working with with our congregate settings there. How could they protect themselves, so their coworkers? One of the unique things that we really learned was that in that sector, a lot of those staff move from facility to facility. And when you have an outbreak, they become the vehicle for movement. So how do we increase access to staff and to reduce that movement was one of our challenges as well. One of the things that we always tried to keep in mind as we were doing this was still ensure access as soon as we could for family members coming in. We talked about the mental health piece. These are congregate settings. We were trying not to close them off as much as possible. There was a time where visitors were restricted, but we tried to work on the procedures very quickly on how they could come in, see their loved ones, support them through these activities, but still keep the outbreaks from occurring within the facility. So big challenge for us, but that was one of our major initiatives. So trying to apply a lot of the hurricane, which is our biggest threat here, natural disaster. So talking about a piece of advice to give, I think one of the things we've started to look at, while these natural disasters are all hazard planning is good, it really deals with more, while complicated, but more predictable things. You know, for us, hurricane is very predictable. We know the season, we know the time frame. We really know what we're going to do within that. We're going to, shelter from the wind and run from the rain is really the model. But it's trying to look at things more from a complex or unpredictable standpoint and become a little bit more adaptive. I think that's really where we struggled early on, and then becoming more adaptive. Greg talked about it as he was presenting, was the 96 hour JACO requirement, but in practice, probably what we saw was not 96 hours for a lot of services. Our healthcare industry is really, their logistics are based on 48 to 72 hours of supplies before they start to get replenished. And when there's a huge surge, as there was for supplies during COVID, those lines get very long. And now all of a sudden, how do you supply some of that? We've been able to work with that in that complicated area when it comes to hurricanes, because we can bring in the services, we have lines, but in these protracted incidents, we didn't have the capability to do that. So I think really one of the lessons learned for us is moving to a system that has some of that framework, how we'll move things around, how we'll do some things, but also have that piece in there where we're going to need to be more adaptive and fall back more on being a little bit more flexible so that we can move and solve things multiple ways is kind of the best advice that we're trying to look at as we move forward.
Interesting. Can I ask a question just on that, which is, I don't want to take us off piece too much, but over in the UK, having people visit was really just not a thing. So in terms of developing new policy, because it's obviously to protect not only the patients, but also the staff workers within that, how did you manage it? What was the impetus?
It goes back to what I originally said. We talked about what needs to be accomplished, that we needed to work on visitations. So most facilities came up with wings there. If they had, if a facility had an active outbreak, we didn't have visitors, but there was no outbreak. And as the medical management got better, so we're talking about medical countermeasures, those types of things. We provide the equipment, extra PPE, those things that they could manage people into outdoor environments. Florida, we're very lucky that
Right.
we can spend most of our time outdoors. So can we do things outdoors? Can we bring them into large settings and allow them to see individuals? It was a big push by most of our health agencies to kind of work on that. So each facility had to work with it, and then we would kind of give technical assistance as they went through their plans.
So if you had some advice for, I think, Aaron, your experience, particularly with residential, is really, really key. And for us as a smaller organization, managing residential is really tough. Now, we didn't, the COVID outbreak in the Cayman Islands was really halted by the fact that they shut the borders. But obviously, when they opened the borders in early 2022, there was COVID, and actually from the end of 2021, wasn't it, Danny? In fact, I was there in quarantine when it went wild, which I was safer inside than I was outside. But anyway, for us, we managed to keep it fairly isolated. There was a couple of people that got it, and all of the protocols went into place. But I suppose my question is when you're busy and you're up and running, we had a limited capacity at that point still because the borders weren't open properly, so we could manage it. But for organizations where you might have more residential, whether it's schools or it's, the Jasmine healthcare crisis, older people, what is your main, like, for us to really have a handle on this going forward, what would you recommend?
Can you restate the question? I didn't quite capture the...
So for residential facilities, particularly where we don't have potentially the infrastructure, we're smaller, but we do have residential people, what would be the most important piece of advice that you would give us in your experience?
I think that's a really multi-level question. So the first piece, I do think, as the doctor said, I do think we need to anticipate we're going to have future outbreaks. And from a residential standpoint, it doesn't matter if it's a pandemic or it's just an outbreak that's going to impact your facility.
Norovirus.
Right. So I'm a proponent of implementing the preparedness piece. So, look at it from what is your plan? How are you organized around it? And I think active conversations and training on how you're going to manage that. So that allows you to have that framework to work within, and then you can adapt from there. I think one of the biggest things that we learned in the congregate setting is that you're never going to have everything that you need, right? Because you can't guess what the next outbreak is going to bring and what's going to be. So I think one of the pieces really is for that isolation is strong logistics lines, right? So how are you going to get support services in? And I can see Danielle shaking her head. I think a lot of it also goes with the communications as well, right? So building those partnerships, what we found really worked for us is, we're used to using one vendor. We really needed to have a better, stronger understanding of where the other 10 vendors were coming from, right? And so I think that's for a small residential is don't rely on a single source to provide you goods. How do you expand that out and work that now?
Danny, you look like you want to say something.
I don't, but I completely agree. I mean, I think those supply chains, even to this day, are still very, very difficult. And I think making sure that you can use your initiative and do it very, very quickly and find a source that, whatever that you need is so critical. So knowing a lot of networking beforehand. I mean, I know I go around nowadays at these sort of hurricane conferences, and I'm doing much more, picking from different people just in case we do need it. That's for hurricanes. But again, COVID's the same thing. It's just making sure your supply chain is solid as it can possibly be.
Interestingly, one of the things that kept us afloat during those early days of COVID was knowing who to talk to. And now that wasn't really published well, because in fairness, everyone was scrabbling. And from the government perspective, they were obviously looking at things in a much different way to us as a small organization. But there was a few people that I knew to talk to who would get me the information. That was actually the FCO, the Foreign Commonwealth Office, the British Foreign Commonwealth Office were absolutely brilliant to us, because I'd just pick up the phone and go, I know that you might not know, but who do we speak to this? And that's how we ended up getting the opportunity to operate as a key business, which was given to us through the Cayman Islands government. Well, we wouldn't have known. We were given good advice. So I think obviously your logistics lines, but your comms lines about just knowing who you would speak to. Greg, How are we doing in terms of internet connection from the small remote island that we're discussing?
Beth suggested I turn off my video, so we'll try that.
That's much clearer.
I think to follow up on that last discussion, I'll give you the example of the nursing homes within the state of Ohio, who, again, another congregate setting here, and similar problems as to what Aaron posed there, to a fairly severe degree. There was one particular nursing facility within one county of Ohio that within the first 3 months of the pandemic had 50% of the total fatalities for the state. So this can have tragic consequences. But they, unlike the hospitals, were not under a JCO requirement that Aaron mentioned there until actually 2020 was their first year. And so we quickly had to put into place, and I would encourage small businesses to develop these relationships ahead of time. We had to link them up with a corresponding hospital and to provide things like infection control practitioners to advise them, and in some cases, some limited staffing to maintain, because as Aaron mentioned, frequently in some of the corporate facilities, they might be traveling across county lines throughout the state to work at one facility one day and another facility the next day, and that's just a vector, is all that is for transmission. So we hook them up very quickly with other hospitals to do that, because what would happen is that became part of the medical surge problem with the hospitals, and this shows the interconnectivity of the system here. When the people were ready for discharge from hospitalization, the nursing facilities were very reluctant to take them back, and for a variety of reasons, whether they were positive or not, to the COVID virus. And what that did would begin to block up the outdoor, so to speak, of the hospitals. And that's what caused surge issues, where we began to set up what Danielle referenced, alternate care centers, a place to take care of less sick people other than a hospital. So working with your partners is huge there, and those relationships are always best developed not during the time of the emergency, but ahead of time, if you can do that. Again, their plans and protocols were poorly developed, and so the hospitals had to kind of step up with that, and then we had to get them together, which is an unusual for them to work together, and eventually the state established nursing facilities that had nothing but COVID positive patients in it to limit the spread. And that took some, in addition to some introductions to working together, some financial incentives on the part of the state. The state stepped up using some federal money, saying, we will pay you to be a facility that accepts nothing but COVID patients. And that kind of consolidated resources, which also helped. The other point of where you might get caught is, I'll give you the EMS response, where we really didn't think about this totally all the way through. The EMS response in Northwest Ohio went very well, because protocols were in place. They had to be tweaked a little bit. I would encourage you, when you're developing your protocols, you don't need to develop a protocol for COVID-19 or the next virus or the next virus, you develop one for respiratory spread, and it's going to need to be adjusted a little bit as we learn about the new virus or the whatever it is. And so you've got to be dynamic and ready to go there, but you don't need a separate infectious disease protocol for everything. The one area that where the EMS fell down, we really didn't consider is that the EMS providers and fire service providers are frequently working 24-hour shifts in their fire stations. So that's a congregate care setting right there. And that presented some issues with trying to limit the transmission of the virus within that setting, and then coming back home, of course, to their families. Some were very worried about that also. So that would be an area. What we did there is if they were exposed early on, until we had a good understanding of the virus, if they suffered what was considered a significant exposure, and defining that took some effort, then we would house them in a hotel separately from their families. So they were not exposing their families until they tested out underneath the various protocols. See, in the U.S., we did not have the robust testing ability that you had here in the Cayman Islands or in the UK. So that became a real issue. And then the final point on to what Danielle, the mental health aspect of this, I will tell you that the pandemic had a tremendous effect on the healthcare professionals within the U.S. and they are dropping like flies out of business, to the point where it'll take a year or two to rebuild enough healthcare professionals within the organizations. When I say dropping like flies, they took early retirement. They just said, I cannot do this any longer. The taking care of patients and being the only one in the room when the loved one died, or maybe dialing up on the iPhone, you can only do that so many times, and it's going to affect you. And those people in the IC units really took early retirement or just found other professions. So watching the long-term mental health of your organization, as Danielle said, is going to be important.
Yeah, cool. Okay, Greg, thank you. I think that we've got a nice summary from all the different speakers. Thank you very much. Just to give a quick recap, I think from Nick's perspective, he was like, you need to be independent and you need to be prepared. There's quite a bit of crossover, and I think it's really nice because it's a very clear outcome. From Danny and Aaron, it's like there has to be anticipation across multiple hazards. And to Greg's point, it's like you can define specific hazard response. It doesn't have to be so definitive that you think you've got the next COVID, but look at, respiratory disease and look at your hurricane. And I think that looking at active comms, training, logistics, there's several which interestingly link into some of the problems that we very clearly had right at the beginning of this presentation. But I think there's two really big pieces of information that have come out of this for me. And one is the ability to adapt and to continue to keep adapting. And the other one is the role of your people and wellness and how that is incorporated. Because I think actually having just done a big, redevelopment of our policies and our protocols, there isn't a cultural element to it. So maybe that's the next step for us, is how do you keep it going? Everybody, thank you very much for joining us today. Unless anyone has anything they'd like to add, I think that we can very gently wrap up. Are there any other questions? Anyone want to bring anything up? Final answer? Excellent. For anybody that is watching, and we will share this so it'll be totally available in your own time. My information is on there if anybody wants any help, I can also put them in contact with Danny. She obviously mentioned all the business continuity planning. Then get in touch with me and we can make sure that people get what they need. Thank you very much, guys. I think that that was very nicely done. Thank you. And we shall speak to you all soon.
Thanks all. Appreciate it.
Thank you.
Thank you.
Cheers.
Take care.